Very good afternoon, everyone. First of all, thank you, Dr. Raja, for the opportunity to come here and discuss a couple of important topics to cap off this session. So, first thing we'll talk a little bit about is applying health economics in the Indian context. Yeah, so we'll talk a little bit about applying health economics in the Indian context, and economics is something that all of us should really know about, and at the base of it is money, right? So, it's important in every aspect of life. So, I'm Dr. Sabyasachi Sengupta. I'm a practicing veterinary surgeon in Mumbai. I did my clinical research fellowship at Johns Hopkins about a decade ago. So the real question is it worth spending so much money, isn't it? So Dr. Abha, she had a great presentation, and she also began with something like this: is it worth spending so much? And the question that everyone is asking, the government is asking, the physician, that is we are asking, the patient is also asking. Oh, you're asking me to get this injection in my eye. Is it worth spending so much money, 50,000, a lakh rupee per injection? Is it worth spending so much? So how do we get to the worth of it? So how do I convince someone to say, even though it's expensive to you, in the long run it's worth it, right? So that's really where all this comes in. And let's also sort of, some basics are that the earlier the impairment, the greater the economic burden to society, right? So a pediatric patient will have will be a burden on society for a much longer period of time, and hence will be much more expensive compared to a slightly older individual. So we are really talking about value based medicine, isn't it? So the cost consideration is one part of it. The human or the patient value is one part of it, and there is a financial value to all of this. So how do we tie in all these together is what essentially we are talking about. When you talk about costs, there are direct medical costs, as we all know. It's about inpatient care and other things. There are direct non-medical costs, where a hospital is involved, where starting from housekeeping to so many other things. There are indirect costs, such as productivity loss, and time for seeking care is not there. Like Dr. Manisha said, people are not coming even if they are getting referred, because they might lose a day's wage. So these are all the sort of costs. So we can actually look at it in terms of direct, indirect, as well as direct, indirect medical costs, and all of these are almost the same. So that direct medical cost is the cost of that procedure to the patient, but at the back end there are so many other costs as well, which we need to think about. And it vision impairment leads to increased likelihood of falls, of accidents. There are reduced educational opportunities for the patient. If somebody is a sole breadwinner, it really starts affecting everybody. There's a lot of gender inequity as well. It can lead to depression. So we've heard all of these terminologies in the previous presentations. Let's create real life situations. Dr. Manisha showed us that image. Let's focus for it for a minute. So this is a 52-year-old diabetic with proliferative diabetic retinopathy. He's the most productive phase of his life, isn't it? People are, even if you look at doctors, from 51 to 60 is the time when they really are earning money. There are this individual has he has to repay loans. He's still under a lot of EMI pressure. His children are still getting educated. There is marriage. So, so many settlement costs. He's the sole earning member. Now, what if he loses vision? There's a high likelihood that he might, right? What would you go, or what would you allow the government of India to spend so that it does not go blind, right? And what would the patient be willing to pay to retain his 6x6 vision, right? So can you put a price on this is the real question. Let's say if you think if you bring in your emotion into this, you can't really put a price on this, right? So this is invaluable. This is something that a patient would be willing to spend whatever he has, isn't it? If he knows about this. However, but if you look at it from a scientific point of view, in real life challenges, the trade-off really. So if you look at it from a government perspective, or from a healthcare spending perspective, there has to be a trade-off between overconsumption and too little care. it is important to make most of the finite resources. Dr. Abha has already told us this, and it is not enough that an intervention is clinically effective, it also has to be cost effective. So we are bringing in the cost into this as well, right? So clinicians need we are already doing this subconsciously, but then clinicians need to weigh benefits and risks, but should consider whether benefits are worth the resources consumed. So how do we do this? So this is health economics in a nutshell. And the three important terminologies are cost benefit analysis, cost effectiveness analysis, and cost utility analysis. There are many other subtypes, but these are the the three important ones. The crux is these are analytic techniques used for economic evaluation of healthcare, and are designed to compare alternative courses of action in terms of costs and outcomes. So if you have three injections, there is a biosimilar, there's a biologic, and there is a better biologic, which one is most cost effective, or which one should the government actually spend money on, right? So the choice of technique depends upon depends on the decision they intend to influence, overall influence. So like I said, basic terminologies before we understand these are, first is QALY, that is quality adjusted life years. It's a measure of health as a combination of duration of life and the health related quality of life. Okay, so how long does somebody have to live, and how much are you going to spend over that lifetime is what is QALY. So if you look at this graph, on the x-axis at the bottom there is time, so from 0 to through life, and on the y-axis there is quality of life, where at 0 is poor quality and on top is great quality. What we want is for the patient to be in the blue zone, right? So we want them to maintain quality of life throughout life, right? And the problem is a lot of patients end up in that red zone where they are old and they have very poor quality of life, right? So how do we prevent all this? How do we calculate QALY for this? Usually which is done using questionnaires. So these are many questionnaires, so I won't go into details of how these questionnaires are. This was a very important Indian quality of life questionnaire. I have a blog on questionnaire development which you can look at. So there are many questionnaires for cataract specific, glaucoma specific, AMD specific. So once you have the quality of life, what we do is do ICER. That is, ICER is cost per QALY, that is incremental cost effectiveness ratio. So this is generally what most governments are calculating. So we can't go into details of how this is done. In the US, any new intervention is going to be allowed if it the cost of that intervention to the healthcare system is 50,000 USD per QALY, right? In the UK there are similar numbers. So when governments look at if they want to adapt, so what if they want to bring in femto-cataract surgery and offer it to patients free of cost? Will they do it? This is sort of the number that they look at. So differences between various outcomes are actually done using these parameters. So what is cost benefit? What we'll come straight to how it is measured. Cost is of course in monetary terms, and benefit is also purely in monetary terms. Cost effectiveness, where cost of course is monetary and effectiveness is measured in non-monetary units. And there are many ways to do it. Cost utility analysis is what they do using QALY, right? So cost utility analysis is generally the best one to do. For want of time, I'll quickly show you some examples. This is health economics and safety considerations for AI applications in diabetic retinopathy screening. They're particularly looking at how AI can bring down costs for screening. Like Dr. Manisha was mentioning, there have been a lot of studies which have looked at many different technologies, and they have clearly shown that the cost of diabetic retinopathy screening will dramatically reduce if you start employing AI. This is an example of that femtosecond search study. This is a large study done in France. And what they found is this is the ICER value, ICER, right? So ICER showed that more than 10,000 euros it will be saved per additional patient whose treatment when treatment success is with phacoemulsification compared with flax. So flax will cost 10,000 euros more. So a lot of complicated analysis goes into these things, but then that's a very high cost for the government to spend additionally. So so the flax has now not been included in any of these major Western countries, and manual phaco is still being sponsored by the state. So how do you choose the appropriate analysis? Basically, so cost utility is the best one to go, like I said. So in summary, value-based medicine really is the need of the hour, and cost utility analysis really should be the cornerstone for what we are doing. Unfortunately, it requires a lot of processes where we need to develop questionnaires with robust methodologies. Then we need to generate data using these questionnaires. Then we need to calculate the quali, and then we need to calculate the ICER, right? So this is a very sort of relatively lengthy process. In India, we don't have questionnaires at all, even for simple diseases like glaucoma and cataract. So it's a relatively long process. Still, for now we can use surrogate measures to assess health economics, which are relatively simpler, such as indirect costs and others that I've showed you. But so this is generally the way forward. We need to first understand what is required, and then go ahead and develop these ICERs for India specific, and then allocate funds for those. So this was a little bit about health economics. I'll take a couple of minutes more, if that's okay.
Yeah, I think the next session people are
Yeah.
waiting.
So I'll just show you,
Summarize.
only two slides on insurance and anti-VGF. This is something that cannot be denied by insurance agencies. I'll just quickly show you. So this is sort of the crux of the whole thing, where the government of India came up with new standardization guidelines. The IRDAI came up with these guidelines from October 2020, where they said that anti-VEGFs cannot be denied insurance. So this is a QR code. If you have the time, you can scan it. So what they've said is intravitreals cannot be denied. The coverage that is allowed is 50% of the sum insured. No minimum was given, but intravitreal injections and especially biologics cannot be now denied. Cannot be denied insurance coverage, right? So we are, a lot of meetings have been done, but overall crux of the story is that that intravitreal injections now cannot be denied. Uh, I think that was pretty much it. Thank you.
Thank you so much, Sunny, and that was wonderful.